my sisters! Welcome back again to another episode of our Becoming or Being Woman Health series. It's very unsettling for me sometimes to always talk about problems of women, but it is important to be able to understand what these problems are so that if we encounter them, we are knowledgeable. And when we know our enemy, we're able to fight our enemy. So, the topic we're going to discuss now is polycystic ovarian syndrome. Okay? It is a common problem. Polycystic ovarian syndrome. It is a rather complex thing. It is a complex problem because it involves a lot of other organ systems or even systems in our body because it falls under almost metabolic problems like almost like diabetes. But polycystic ovarian syndrome, I'm getting my lecture mainly from Pathophysiology, Biology of Diseases by McCann's and Heathers. And it's a little bit complex, but we'll try and make it understandable. So polycystic ovarian syndrome, poly meaning plenty, ovary, ovarian, of course, polycystic in ovaries, and the syndrome. A syndrome means a group of manifestations that make up a disease process. So polyovarian syndrome, okay? So polyovarian syndrome is a common, serious, condition that has serious physiologic and psychological health consequences. So we're getting to discuss more difficult and more serious problems this time. Polycystic ovarian syndrome is a common condition with serious physiologic, meaning the functions in our body will be affected, and psychological health. So psychological as well. So not only in your reproductive tract, but even in your thinking process. So it's very important because it can affect you. The consequences can be very difficult to manage. Okay? So polycystic ovarian syndrome affects women across the reproductive lifespan. Not only in the younger ones, not only in the older ones, but the long reproductive lifespan of a woman, and is associated with pregnancy complications, including diabetes, preeclampsia, which is hypertension in pregnancy that has dire consequences, and large for gestational age babies. So that's why we need to know this. We need to deal with PCOS because you see now it's involving now gestational big babies and difficult deliveries, hypertension in pregnancy, and diabetes, especially of the type 2 version. But then when you're pregnant and you have gestational diabetes, you might even need to be using insulin. So it is really a complex disease with complex consequences. We need to deal with this. PCOS also is associated with excess weight gain. So usually the ladies who suffer from PCOS, they are on the heavy set, okay? Then if they're on the heavy set, it exacerbates the health burden that the woman has to bear, okay? So PCOS is associated with excess weight gain, which in turn exacerbates the health burden of a patient or a lady with PCOS, polycystic ovarian syndrome. So let's go further and describe what PCOS, okay? It is a process, it's a disease process that is one of the most common causes of anovulation. Anovulation meaning she's not ovulating, therefore she's not menstruating. And if she's not ovulating, there is ovulatory dysfunction. Anovulation and ovulatory dysfunction, no menses, no ovulation, no pregnancy. So I find PCOS very common. The diagnosis, the common differential diagnosis, there are other things that manifest as polycystic ovarian. They seem like they're polycystic ovarian disease, so we have to rule them out. So common differential diagnosis is thyroid dysfunction. So sometimes ladies with thyroid problems may manifest that you look at them, you think, oh, this woman is suffering from PCOS. Actually, when I walk around and I watch, I like watching girls passing by, and I said, oh, this probably has PCOS. But it's not always the case. Sometimes we think they're PCOS, but they might have thyroid problem. Also, hyperprolactinemia. Remember, prolactin is the hormone that's released by the pituitary gland that that helps or stimulates the breast to have to produce milk. But when you have this kind of problem where your pituitary gland is secreting too much prolactin, it might manifest like something that would manifest as polycystic ovarian syndrome. You also have congenital adrenal hyperplasia. So we have some women who are born with the adrenals problematic, okay, the adrenal hyperplasia, and may manifest like somebody who looks like having the manifestations of PCOS, but really the problem is the adrenals. So these are the common differential diagnoses that come about manifesting like PCOS. So you need to rule this out because these have dire consequences. Then PCOS is strongly associated with metabolic dysfunction. In other words, metabolism is affected when a lady has PCOS. You don't want somebody with metabolic disease. So PCOS that has metabolic dysfunction manifests as dyslipidemia. Now, dyslipidemia means triglyceride problem, lipid problem, high LDL, high triglycerides. So the cholesterol levels are dangerous. The triglyceride levels are dangerous. That's dyslipidemia. And you don't want that because a person with triglyceridemia or dyslipidemia or problems with their fat in their bloodstream will be prone to developing atherosclerosis and or stroke and heart attack later in their lives. So PCOS, dyslipidemia, and then make yourself prone for stroke and heart attack. So you don't want to live PCOS unmanaged. The next problem with PCOS that is affecting metabolism is insulin resistance. So what is the very common disease we know that has insulin resistance? It is diabetes, okay? So diabetes mellitus is a problem of insulin resistance. We all know it's very common out there where the sugar in the bloodstream cannot enter into the cells. And so the cells will suffer from like hunger for carbohydrates or glucose specifically. But then glucose is high in the bloodstream. And when it's high in the bloodstream, it can wreak havoc across the other organ systems and cause problems in your regular life. Okay, so another one is obesity. So many ladies with PCOS are obese. Okay, and when you have obesity, you're prone to heart attack, you're prone to this, you're prone to that, a lot of other metabolic problems or problems that will come because of the person being on the overweight side. So we don't really like polycystic ovarian syndrome, but it is common. It is a very common symptom of an ovulation. So with a woman is that having menses, you try and see, especially if she's on the heavy side, to be aware that she could have PCOS and therefore is she would be somebody who is prone to develop metabolic dysregulation or dysfunctions. So and they will suffer from the consequences of these problems that can set in. So let's go forward on polycystic ovarian syndrome, and we have some other problems. Okay? Now, it's not only a leading metabolic problem, it is also a leading endocrine disturbance. Okay? Polycystic ovarian syndrome is a leading endocrine disturbance that affects especially now in young women. Although it affects women across the board in the reproductive life, because it's a myriad, it's a syndrome that affects a lot of other systems in the body. It's very common and the leading endocrine disturbance. If ever there's a young woman with an endocrine problem, most likely it is PCOS. Okay? So it is a leading cause of infertility in the United States. Also, leading cause of infertility because in the United States, we're heavyweight people. So when you're heavyweight people, heavyweight ladies, you're prone to develop PCOS and with a high 5 to 15% prevalence rate. So there's a lot of women who are suffering from this. Okay, and it is strongly genetic. There, it runs in your bloodline. It is hereditary. So when your grandma, your aunties, your mom, your and women in your family that has PCOS and has obesity, has all this diabetes and cannot get pregnant, they most likely are having PCOS, and you can have it too. Okay, so you have all these differences also, and the different components associated with PCOS may also be passed, but not always, okay, in different ways. Hypertension, dyslipidemia, and diabetes, it's not always the same picture in everyone, but they are still suffering nonetheless from PCOS. Okay, frequency, expression, and timing makes diagnosis difficult. Okay, so it's not always coming out at a certain age. It does not always show the same way. It does not always come out with the same manifestations in every lady the same way. Okay? Oh, frequency, expression, and timing. So you have to be like, okay, I have to be watching for this. That your health practitioner should be, knowledgeable on this. But we as women should be even more watchful for our bodies per se, because we are the masters of our body, right? And we are supposed to be knowing these things that can happen to us and result in problems later. It has a 22 to 30% have polycystic ovaries on ultrasound. Now, I was a sonographer. I do OBGYN sonography, and you can see the ovaries full of eggs that are plump and wanting to ovulate, but they are not ovulating. And a third of the ladies with PCOS have polycystic ovaries, okay, on ultrasound. And 80% have one or more symptoms of this syndrome. So when you're doing ultrasound, maybe they're not really manifesting as PCOS, but 80% have one or more symptoms of the syndrome. If you're doing an ultrasound and you see a lot of eggs in the ovary that have not been ovulated. 80% of women with normal ovaries may even have one or more symptoms of the problem. Although the name is Polycystic Ovarian Syndrome, 80% of women with normal ovaries may have one or more symptom of the problem. So it's very tricky. It's a tricky manifestation, disturbance in women. So it's really nice to sort of understand what polycystic ovarian syndrome is. The manifestations of PCOS women, how it manifests in women, PCOS manifests, they are varied. As I said, there's different ways by which it manifests, different times, different occurrences. So the manifestations of women with PCOS are varied over time, with metabolic syndrome becoming more prominent in the life of that woman with PCOS. Now, metabolic syndrome is another syndrome that can be something that a sequelae or something that comes out of PCOS. Metabolic syndrome involves your being overweight, okay, with a hip to abdomen or abdomen to hip ratio that is abnormal. So sort of on the fat side, they have hypertension, and then they have insulin resistance. So you can see this. There's a lot of women like this. They're overweight, and then they have on top of that hormonal problems, and then they have androgen. Androgen is sort of like the male-like-ish hormone that will cause them to have some manifestations as androgen positive, okay, excess positive. So you have to watch for this one also. Okay, and polycystic ovarian syndrome it can be associated with a lot of other endocrine morbidities. So PCOS can be associated with other endocrine. It is the most common endocrine problems in young ladies, but then it is associated with even more. So it's like when one endocrine organ is suffering, it looks like the other organs in the endocrine system will also sympathize. So when you have your ovaries problematic, your adrenals will come into play, your thyroid will come into play, and you will have androgen producing adrenal and ovarian tumors and other symptoms that even produce hyperprolactinemia. So, oh my, a lot of other organs in the endocrine system are affected when somebody has polycystic ovarian syndrome, hyperprolactinemia. It is something that is encompassing. It's almost like when a man has diabetes mellitus, whether it be type 1 or 2, or a woman has diabetes mellitus, either type 1 or type 2, a lot of organ systems are affected the same way with PCOS because it is a metabolic and endocrine problem. Okay, so we go further and learn that the manifestations are varied at any time in the reproductive life of a woman, but very common in young women as a metabolic or an endocrine problem. So what are the presenting signs and symptoms, or what portion or what percentage of women are affected by PCOS? Very common. The 41% of women with PCOS are on the heavy set. Okay, 41%, almost a half of the population with PCOS are overweight. 70% have dysfunctional uterine bleeding, something wrong with the menses, menstrual disturbance. 70%. Okay, very common. Oligomenorrhea, meaning very far in between menses, very far. So they're not regular, they're very far apart. That's 47%. You have amenorrhea, absent menses. She's not ovulating. She ovulates very infrequently. Oh, very infrequent ovulation, very infrequent menses, oligomenorrhea, absent menses because no ovulation, amenorrhea, 19%. Regular menstruation, though, is present in some, 48%. Oh, interesting, you know? So they think that they can get pregnant, but unfortunately, they have PCOS, even if they have regular menses. Then you have what you call the hyperandrogenism, which is high percentage, 69 to 74%. Hyperandrogenism is when androgen is the male hormone-ish is increased in the bloodstream. And when you have hyperandrogenism, because the precursor to androgen is a precursor to testosterone, and when that's increased in a woman who's not supposed to have testosterone but has the precursor, she will manifest with masculine features, and so she will grow whiskers in her face, like she's gonna grow a mustache or a beard. That's we will study that a little bit more. Hyperandrogenism, very plenty, 69 to 74. And then you have infertility, 73%. Yeah, I know that. I have experience. I've had patients with PCOS, but we just try and manage them, and they get pregnant, but they're still PCOS. It's not taken away. But we have to deal with that and teach them how to live a little bit more healthier. Okay, because it grows across the lifespan of the woman. Once she has it, she got it from her forebears, she's gonna have it. But what's scary is a fifth or 20% are asymptomatic. They don't know. And then they'll be the ones who will suffer from stroke. They're the ones who suffer from heart attack and the complications of metabolic problems such as insulin resistance. So you want to check on women regularly, or women should come and have themselves checked in regularly for the possibility of PCOS, especially if they're on the heavy set side. Okay? So these are the manifestations of PCOS. So we come also to some more how it manifests as hormone problems, hormonal disturbances that manifest in PCOS. Oh, there's plenty. So because this is a metabolic thing. And even just the production of one hormone in our body, the hormone in the hypothalamus going down to the pituitary, from the pituitary going to the ovaries, and the ovaries going through a lot of whatever processes to come up with your estrogen. So there's a lot of processes, a lot of hormones, and then when estrogen is extruded into the bloodstream, there are carrier proteins that will bring your hormones to the proper places where they're supposed to work. So a lot of steps can be affected in this process, and because of that, then it will manifest in different ways. Okay? So first hormonal disturbance is increased insulin. Okay, you said diabetes and insulin is not a problem. No, it's not. Because in insulin, hyperinsulinemia would be when insulin is very high because the sugar is a lot in the bloodstream, cannot enter the cells. And the cells are telling the pancreas, please give us sugar, please give us glucose. But insulin is now working. Okay? When the cells are calling for sugar or glucose to come into the cell, the pancreas says, here, I'm giving you more insulin so that it can enter the cells. Insulin is the one that gives the instructions for glucose to enter into the cell. But insulin is being produced, but there is resistance to insulin, and sugar cannot enter the bloodstream. There's increased insulin. And when there's an increase in insulin, it has associated metabolic problems. You don't want those things. Okay? You have also decreased, oh, sorry for the she, that's not she, that's sex, okay? SHBC, sex hormone binding globulin. So this is the hormone that's ferrying the estrogen through the bloodstream to the target organ. When you have the sex hormone binding globulin abnormal, not there, then even if the hormone is there, present there, the hormones are normally produced, but there is no ferry, there's no because you see these things are big proteins floating in the bloodstream, and the bloodstream is aqueous, water medium, and this our hormones are steroid-like, or they're fatty-like, okay? And they will not float in the bloodstream. They cannot go through our system. So they need to have a globulin or a protein to carry them to the places where they are supposed to be used. So if you have a decrease in your sex hormone binding globulin, no way you can, if you have a decrease in that, you'll not be able to get your hormones to work properly. Then another, we had said earlier, hormonal disturbance in PCOS, you have increased androgens, or the male-ish hormone that is going to become testosterone, or androstenedione, which are male characteristic inducing hormones. You can get this a lot in men, but supposedly not in women. But when they have PCOS, this one is increased. And you also have DHEA increase, dehydroepiandrosterone occurs in 50% of women. This DHEA is also one of the precursors for testosterone. You have increased LH, okay, luteinizing hormone. Remember that luteinizing hormone is in the middle of the cycle so that the woman can ovulate. After follicle stimulating hormone is released and the eggs are growing, luteinizing hormone is released so that she will ovulate, right? But here in this process, there is an increase in luteinizing hormone, but the eggs do not extrude. The eggs do not ovulate. The ovaries do not release the egg. So then it's saying, the body is saying, oh, she did not ovulate. She didn't ovulate. She did not ovulate. So LH is being given out. You need to go. You need instructions are being given. Ovary, please do your job. Ovary is not doing its job. So therefore, there will be an increase in luteinizing hormone. Then you have increased prolactin, more of prolactin from your pituitary gland. There will be, because of your being hyper, on the heavy side, leptin, which is the hormone that says stop eating, and ghrelin, which is supposed to say I'm hungry. The leptin ghrelin thing will be disrupted. And so you go bigger and bigger and bigger. The leptin ghrelin mechanism will be problematic. So another hormone, leptin is a problem. So it is suggested that decreased, they have what you call the insulin-like growth factor. The insulin-like growth factor receptors in the theca cells. So you have insulin-like growth factors in the theca cells. This is important because if you do not have this, it's suggested decrease. So then it cannot work that way. There will be a problem in this aspect in the theca cells, and the theca cells won't work properly. You have possible estrogen receptor differences or problems. So intraovarian along with hypothalamo-pituitary axis problems. So a lot of hormones are affected, not only one. So if you have a lot of hormones being affected, a lot of organ systems also are affected by PCOS hormonal problems. So we're done with the hormone problem. So I will show you sort of like from this International Journal of Molecular Sciences review, PCOS syndrome, a comprehensive review of pathogenesis, management, and drug repurposing. So this is a very complex picture here. Let's just say in the middle, you have PCOS, a Polycystic Ovarian Syndrome. And it is a cycle, okay? So one begets the other, begets the other, begets the other, begets the other. And all of this will affect the ovaries, okay? Plus mental stress on the adrenal gland. And then in the end, you would have an ovulation, and then you would have irregular menses. So our lifestyle that cause different epigenetic changes and changes in our manifesting DNA can affect androgen production, okay? Environment toxins like BPA or bisphenol A, which we can get from cans, linings, water bottles, etc. And glycotoxins too, they can also make an increase in androgens. They are very strongly estrogenic. They are xenoestrogens. Your dietary factors, increase fat in the food, increase carbohydrates, especially refined, and no vitamin D supplementation, you can get insulin resistance. Your muscles do not break down sugar in your bloodstream. So you have hyperinsulinemia, which affects your pancreas. Then your liver is affected with all your hormones and problems that your liver does. Your adipose tissue is affected. They increase problems. So you have this cycle of problems that affect your ovaries in the end and resulting in irregular menses. So can you see a lot of organs are involved in this problem of PCOS? So how does PCOS manifest? Why you're telling me this, and that? What is PCOS now, okay? It's not only a polycystic ovarian syndrome. What is it like? What does it manifest? So it has, I said, you have to manage because it has possible late sequelae or consequences that will come later in the life of the woman. Well, dyslipidemia. You know, we have to control our cholesterol, triglycerides, bring them down. With dyslipidemia, you have increased low-density lipoproteins, decreased high-density lipoproteins, increased triglycerides. You want this one. In dyslipidemia, the LDL is bad cholesterol, they call it. I call it luciferic density lipoprotein, bad. And then you have the HDL, heavenly density lipoprotein. They're decreased. You want that high. You want the LDL low. But they are abnormal when you have dyslipidemia. Problematic. You make yourself prone to atherosclerosis. You make yourself prone to hypertension. You make yourself prone to stroke and heart attack later in your life. So PCOS, dyslipidemia, stroke, hypertension. You don't want that. Okay? And then we have diabetes mellitus. 30% of women with or without obesity develop type 2 diabetes mellitus by the age of 30. So if it's in your bloodline to have PCOS, you're more or less gonna have you're more or less going to have diabetes as you reach the age of 30. Nobody wants to have diabetes mellitus. So we have to check for this thing. And then you have endometrial hyperplasia. The lining of your endometrium is very, very thick, and you get bleeding, and then you can have cancer, carcinoma of the endometrium, or cancer of the uterus. In anovulatory women, because they are hypoestrogenic, meaning they hyperestrogenic. They have a lot of estrogen. They're bombarding the endometrium, and the endometrium is just growing, 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 and they're not ovulating. High estrogen is there, so the endometrium is just growing, growing. No progesterone, because progesterone comes after ovulation. So what's going to happen to the lining of the uterus? It grows, and then you have bleeding, endometrial hyperplasia. And if it's not well controlled, your lifestyle is bad, you will most likely have carcinoma later if you do have hyperplasia in your uterus because of PCOS. Other clinical manifestations, you have women with PCOS are at an increased risk of gestational diabetes. We talked about this. Pregnancy-induced hypertension. So they can have hypertension in pregnancy. They were insulin resistant, so they're going to have diabetes in pregnancy. They can have preterm births, and then they have prenatal morbidity because it's harder to manage these women with diabetes and pregnancy. So it is right. Can you already see that you have a lot of problems when you have PCOS? Watch out. Always. That's why even if you're not sick, oh, I'm not feeling anything, I have regular menses or I have irregular menses, we got to have ourselves checked somehow. If you have 1 or 2 or 3 of these manifestations, get yourself checked because there are problems associated with this kind of manifestations, okay? So the diagnosis, therefore, is supposed to be important and taken into consideration. So we have here the picture. We have here hirsutism, which is a manifestation of hyperandrogenism. Well, anyway, let me go finish this here. So here is hirsute. She's growing a mustache and a little bit of a goatee here. This is hirsutism and some hair in this area. Okay, androgen excess. They call that hirsutism. So she grows this one, and then chronic anovulation. She does not ovulate. She has irregular menses. And then she has polycystic ovaries. So this is the ovary sort of. And this is a picture. If you're going to look at it, you cut your ovaries and you would see a lot of eggs that were not ovulated. So when you're going to use this, when you're going to look at this on ultrasound, you would see an ovary with a lot of cysts. Therefore, that's the name Polycystic Ovarian Syndrome. And other tests also, because this woman has insulin resistance, we talked about that, we have to check for the glucose tolerance test. This is a test for diabetes. So when she has abnormal menses and polycystic ovarian syndrome, we check for the glucose in the bloodstream and how the woman behaves, how her body behaves to glucose tolerance test. If it is abnormal, then she has insulin resistance, and you will be able to complete the diagnosis for PCOS. And therefore, you have to be aggressive in the management of PCOS. So this is what it is like, our picture. This is a normal ovary on the left. You have a very a mature egg that is just going to be ovulated, and these are corpus luteums after she has ovulated. This is what you would see in a normal ovary. But if you have a polycystic ovary, you would see a lot of eggs, and they especially are in the periphery here, big, and they call it like rosary beads, on ultrasound. You would see them at the periphery mostly, and they call that, because you can have a lot of cysts in your ovary, but it's not polycystic ovary. But when you have a lot of eggs or follicles in the periphery, especially like a rosary beads, like boom, 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 like this, then they call that, they'll diagnose that as polycystic ovarian picture by ultrasound. So what now are we supposed to do? So we have 4 goals in the management of PCOS. Okay? There we are did you see that we have a lot of organs affected? So our goal is not only one. Our goal is fourfold across the board. 4 goals for the management of PCOS. You have to reversal or check on or manage androgen excess. She's a girl. She's not a dude. Okay? So therefore, she's not supposed to have this thing here or this thing here. You have to reverse that, or you have to manage that reversal of and the management of androgen excess, because and this young girl will become very insecure of herself. People are out there and they're mean sometimes, and they bully and they call you names. So we don't want this. We don't want our young women to have this thing, or any woman for that matter. Then you have your goal. One of the goals is to institute a regular cyclic menstruation. Want to bring her cycle into regularity. Then restore fertility. So one of the goals is to restore fertility, and the fourth one is mitigating or stopping or slowing down the process of developing metabolic or endocrine disturbances. So we really want to check our androgen excess. We want to deal with the menstruation, making it regular, because already we know that you become that, you have no ovulation, you have no estrogen, you become osteoporotic. You don't want that. You have to restore fertility. You have to mitigate the possibility of endocrine problems later in the life of a woman. It is a problematic syndrome. So we deal with this seriously. Okay? Management of PCOS. Now, there are first line of treatment, and they're two-pronged. If the pregnancy is desired, and if a pregnancy is desired, and or if a pregnancy is not desired. Okay? So first we have, okay, let's manage PCOS. I don't need to get pregnant. So they give out. This is management in the regular allopathic medicine. They give combined oral contraceptives. So they give you a contraceptive. So to manage your hormones, that you manage the hirsutism, you manage the acne, you will cause regularity of menses. Those with insulin resistance or those that do not respond to contraceptive therapy may benefit from insulin sensitizers. So they're given insulin sensitizers. So the cells open up to glucose. They are not insulin resistant anymore. So they're given metformin, manage the metabolic problem. And combined oral contraceptive pills are not used, and pregnancy is not desired if that is so. Progesterone therapy is instituted to oppose the excess estrogenic effects on the endometrium so that there will be no bleeding. And this is given to initiate a monthly withdrawal bleed. So when they do this woman, when they give progesterone, then the woman will have regular menses if she's taking regular progesterone to have a withdrawal bleed, like a menstruation. So this is for pregnancy that's not desired, first line of treatment. What if she wants to get pregnant? Okay, now she has PCOS, but she wants to get pregnant. Okay, if the woman is obese, overweight, lifestyle modifications, which include regular exercise, weight loss, is the first line of treatment. Again, we go back to lifestyle. You have to have weight loss. You have to have regular exercise to control your fat, because the fat is the one that can get in the way. Even a small reduction of weight restores ovulation and increases insulin sensitivity by 71% in obese women with PCOS. So if we're going to make her exercise, to check her food, to check her stress level, just so that she will lose a little bit of weight, when that happens, 71% of obese women with PCOS, they can get pregnant. I've seen this happen. It did happen. It's not that hard. She exercises, she eats properly, she sleeps well, she's early, she does all the natural remedies. Within 2 to 6 months, she gets pregnant. Her uterus starts, her HPO axis starts working out, and she gets pregnant. It's really, it's like, hallelujah. The body is marvelous. We have been made to bounce back quickly, to work and do the work that our body needs. We have 2 X's in our genes, right? chromosomes rather, XX. We have double strength. We are the helpmeet. We're going to be there. We have the strength to do the things we need to do. We come up to be the partner of somebody who's working so hard. So you know the not that all women should be like subservient helper meet to the husband, because sometimes now in these days the woman is the one that's the main bread earner in the family. But in general, we're still, even if we're the bread earner, we're still the helpmeet for our husbands, right? Such a difficult thing to do, but we need to do it because that's the God ordained work we are supposed to be doing. So reduction of insulin by loss of abdominal fat appears crucial in restoring ovulation. We need to take care of the weight so that we can have less hyperinsulinemia, less sugar problems, less of the rest of the complications that come. Now, regularly they give clomiphene citrate, which is a drug, and anti-estrogen, medications against estrogen. They can be used to facilitate ovulation and may be combined with metformin to get improved outcomes. This is the regular management for PCOS out there. Okay, so how about if the generalized regular management of PCOS? Okay, so let's deal with the regular management of PCOS. Management of PCOS is nearly lifelong. So our woman's across her life, just because it just doesn't disappear. Across her reproductive life, because it manifests in different organs, so therefore they're there all the time. So it's very important that we know these things. The management of PCOS is nearly a lifelong process, because it's a syndrome and it persists past childbearing years. You don't only get a stroke when you're during childbearing, it's even after. So we have to watch that. Appropriate primary care is needed. Appropriate care, primary care. Primary, usually the preventive one is more important to control the systemic features of PCOS. What are we supposed to do, sister? We want to do a control for this to minimize the impact on the life of the woman who has the problem. Okay, I see that this one to me is very interesting. I really like this one. Early programming for PCOS. Okay, a fetal, according to Diamante Kandarakis and Dunaif in the Endocrine Review in 2012, in this article, it said, a fetal environment containing abnormal levels of pollutants, hormones, and other factors yet undefined can induce epigenetic modifications of the DNA and increase risk for adult disease. So this means that if the pregnant mother is not taking care of herself, she's not taking care of her baby's future. If I do not take care of my baby when I'm pregnant, I just don't care about pollutants. I just don't care about the hormones here and there. I don't care about what I eat. I don't care about what toxins there are out there that's affecting me and other factors. That I just need to be taking care of myself. I don't. Okay? So then these things can affect the DNA of my baby girl. And if they change the genetics of my baby girl, she's gonna get prone to have the same problems that I have. So that's epigenetic changes. So that's why the Bible says, when you're pregnant, I think I read it somewhere, a pregnant woman who is prudent will have a prudent child. So you want to be taking care of yourself because you want your child to be healthy and your grandchild to be healthy as well. Female fetuses exposed to testosterone, whatever's in the environment, at levels normally found with male fetuses, appear programmed to develop altered TGFB. TGFB is transforming growth factor beta, and the signaling and increased risk of hyperinsulinemia and hyperandrogenism related to PCOS. Okay. So when I'm not taking care of myself and I get a level of the androgens higher in my bloodstream, even when I'm pregnant, this little baby of mine is going to have PCOS also later in life. I don't want my baby to have it. Neither do I want my granddaughter to have it. So I have to be careful because what I do is going to affect my daughter and it's going to affect her daughter as well. So we have to go and be watchful. So we have regular management of PCOS is desired. We outcomes of weight management program in women with PCOS are likely to be improved with the inclusion of behavioral psychological strategies, including goal setting, self-monitoring, cognitive restructuring. It's a lot of things to be taken into consideration. So it's like a myriad of disciplines taking care of one woman with like diabetes. You have the nutritionist, you have the oncologist, you have not the you have the nutritionist, you have the endocrinologist, you have the internal med regular doctor. All these PCOS is not different. It has a lot. There's even psychological strategies, cognitive restructuring, how she thinks, she'll be watchful. All these things, all given so that a woman can fight her PCOS. Strategies targeting improved motivation, social support, psychological well-being are also important. We want our women to be the most healthy and bring them there to a little bit healthy lifestyle so that she will get better. So we have a lot of different kinds of what they call this managements and natural remedies for PCOS. Again, weight loss is very important. Even to 5 to 10% decrease in weight is already a lot of difference. Exercise, we already talked about that. And it's important to get 120 minutes of moderate or 75 minutes of vigorous and intense exercise per week. Exercise without diet can resume ovulation even without diet. Exercise even without diet. But what would do if you have exercise plus diet? Even more, right? Diet, fiber rich, watch your glycemic index, control any sugar problems that you have. So diet, weight loss, and diet, exercise, very important. Okay, you cannot really get away from that. Now, you have supplements. You can do vitamin D, you can do resveratrol, you can do omega-3, berberine or what they call this, golden seal, folic acid, myo-inositol, D-chiroinositol. All these supplements you can find, and they're good and can help control your endocrine problems, right? Okay, then, they have found out that PCOS is not, they have found out that PCOS is not managed alone by a doctor that does only gynecology. It is a complementary and alternative medicine problem. Okay, so in other words, a lot of people are involved in adjunctive management of our patient with diabetes. Because if not, then your management of PCOS will fail. So they go into complementary and alternative medicine, meaning they go lifestyle changes involving nutritional, psychological, physical, and a combination of all these natural things and a combination of all psychological things, because it's a myriad of problems that this woman has. So we want to help her there so that she can get better. But you see, many times we try our best to get pregnant. I really want to have a baby. And the Lord says, no breaks. Don't have baby. You can work for me better without a baby. Oh, but I really want a baby. Remember the story of Rachel? Rachel, the wife of Jacob, Leah was giving birth, and then Rachel gave her handmaid, Leah gave the handmaid, and then finally Rachel had a baby, Joseph. And then, I want some more baby, one more. And she gave birth to Benjamin. And what happened when she gave birth to Benjamin? She died. So sometimes, we don't push our agenda. God really knows better, right? God always knows. And His ways are always better for us. As we surrender our wills and our desires to God's will, then we get the best that we can. Being contented. That's why it said, in all things be contented. In all things rejoice. Whatever trials and difficulties, even if there's a thorn in our side, we can be content. We can give thanks by what God has given to us. We don't want to be continuing in our sickness, in our PCOS. Of course, we will try and deal with that. It's not good to be complacent because, God, let me go. Let me be PCOS, therefore I should just be content in my PCOS. No. We want to be the most healthy in the world that we can be, so that the Lord can use us mightily. So, so far we have discussed PCOS and it's so many things to understand, but lifestyle changes can always help our changes for good, obviously, with good exercise, sleep, eating properly, and weight management, and stress management. All these can help our patient going out in the sunshine, exercise, etc. I cannot overemphasize the importance of taking care of your bodies the way God wants you to, because that's how we will be able to take care and do the best that we can do for God. So let us bow our heads for prayer. Gracious Lord, our loving Heavenly Father, you are mighty to save. Nothing can perturb you. Nothing is ever missed. You know everything. You left heaven. You emptied heaven for us. You suffered everything that we have suffered. So what are we doing down here and complaining when you even suffered already for us and you can understand exactly what we are going through? Father, thank you so much because you are an understanding God and you know what is best for us. Help us, Father, to submit to your will every day. Help us, Father, to be guided, to follow your laws and your statutes, so that at least we can get the results of the promise you have for each one of us. We want to serve you. We want to be there for people out there that are languishing in sin. We want to be out and saving more souls for your kingdom. Thank you so much, Father, for the privilege of doing so. We thank you that you keep our names in the book of life. We thank you that you will sustain us through all our trials, because we need you, Father. We cannot do anything without you. So help us depend on you. We give you our will, everything we have, everything that we are, for Jesus' sake. Amen.